this case of the month from the PSOGI that will be dedicated on gastric peritoneal metastases. First of all, many thanks to Aditi and to all the work she is doing to get this case of the month every month to this Zoom meeting. And many thanks to this prestigious expert panel with Paul Sugarbaker, that it's not that we will not present. Everybody is knowing him. Sanket Mehta from India, Wan Pang Yong, a medical oncologist, the only medical oncologist for this case from Singapore, Clarice Evno from Lille, and Clara Marie Shulin-Chia, also from Singapore. So Singapore is the majority for this case. One surgeon was medical oncologist. Many thanks to all of you. I propose to present the case, and I will, during my presentation, probably and certainly ask to some of you some question. This is a complicated case, a recent case. Do not hesitate to criticize our management, to discuss our management, and to get a lovely discussion. So I have no disclosure. This is a very young female without any medical or surgical history, that had weight loss of 15 kilograms with diffuse abdominal pain. So she gets an endoscopy that discover gastric adenocarcinoma with laminitis, and no surprise from the initial pathologic report, poorly cohesive independent cancer cells, this poor pathology prognosis. We did a CT scan that showed and confirmed this laminitis, mainly located in the antropyloric area, with lymph nodes around the tumor, and with an initial transverse colon infiltration and intraperitoneal fluid. So this is the images that we had on CT scan. You saw peritoneal fluid. You saw this big laminitis that appeared to be distant from the head of the pancreas. You saw the infiltration of the colon, the transverse colon, of the mesocolon, and probably on the mesentery of the first loop of jejunum. And when you are getting down, except fluid, you do not see any other signs of peritoneal disease. The ovaries particularly appeared normal, but you have some liquid there. So this was the initial CT scan. So they decided to perform in another center a laparoscopy, and this laparoscopy confirmed what was evident on the CT scan, that the patient had peritoneal metastasis with nodules on the parietal peritoneum, mainly in the upper part, in the right and in the left upper quadrant, but also in the gutters. And it confirmed also the involvement of transverse colon and of duodenal junction, duodenojejunal junction. I had not the images of this laparoscopy to discuss perhaps first the goal of laparoscopy. Of course, if you have no evidence of peritoneal disease, and in every advanced gastric cancer, it is mandatory, because we all know that it will allow to detect occult peritoneal metastasis. with a mean frequency of 28% in all these trials, and we only have 5% of false negative. In this particular patients, I think that laparoscopy was still mandatory because it allows a precise evaluation of the peritoneal disease extent. We all know that we have a problem with the evaluation of metastatic gastric cancer with peritoneal involvement is that the RECIST criteria are often not applicable to peritoneal disease, explaining that we have a low rate of inclusion of patients with peritoneal metastasis into trials. And maybe we will discuss this. This is a problem. We know also that we often have a differential response between response in the primary tumor and in the peritoneal disease. And in this case, before starting one treatment, it was interesting to get by laparoscopy the pathologic confirmation that these patients have a metastatic disease. So maybe regarding the systematic laparoscopy, Clarisse, do you want to make a comment in advanced gastric cancer? Your microphone, please.
Yeah. I think you will tell us later why, but yes, it's very important because the CT scan that you show us is already showing some sign of peritoneal disease because there is ascites and everything, but it's very important because to make the laparoscopy, even if you don't see any kind of involvement of the peritoneum or ovarian metastasis or ascites, you will find some disease, peritoneal disease, in more than 30% of the patient, even if you don't see anything, because it's small disease and we don't see anything at the CT scan. So it's very important to do it at the beginning of the staging, because you will not treat in the same way patient with metastatic disease or only with locally advanced patients. So yeah, we need to do it at the beginning to give the proper treatment, and also to do it with the right way. You need to look at very well at the small bowel at the beginning of the history, because you can have some small disease. Even if your PCI is low, you can have some small bowel involvement that will classify the patient in non-resectable patient with some disease on the small bowel. So even at the beginning, you need to watch very carefully the bowel, because it's where you will find some non-resectable disease. So yes, we need to do it early with an extensive approach, and we will find some disease.
Okay, so unfortunately, even if this is a safe procedures, this kind of procedures can lead to some complication, and the patients experienced a peritoneal hemorrhage that should be, and she was reoperated by laparotomy to do the hemostasis into the pelvis, probably on biopsy area, so the patient gets at this point of time a laparotomy. And you will see that it will have some consequence for the future. We get, following this, more information, and this information is today probably very important in the area of new targeted therapy, the molecular biology. She had a positive peritoneal cytology. She was pMMR, HER2 negative, CPS 5, and she was positive for the Claudin 18.3. So, following these results, she was discussed in a non-expert centers in a multidisciplinary team, and it was decided to give the first-line palliative systemic chemotherapy, and the choice that was done at this point of time was FOLFOX plus the targeted therapy against the Claudin 18, the zolbetuximab, for 6 cycles. So maybe Wei Peng, do you have a comment on this choice? Would you do exactly the same at this point of time? Would you do differently? What is your advice? Your microphone. What?
Okay, great. So this is a great question. For this young patient, I agree absolutely that we need to check the MMR. So she's HER2 positive, but CPS is considered moderate PD-L1 score, which means that in some countries you can use chemo and immunotherapy, and in certain countries where zolbetuximab is available, we can also use chemo or plus zolbetuximab. So how does medical oncologist choose between whether immunotherapy or zolbetuximab? Well, there are several important factors. For example, for those with high CPS score, particularly greater than 10, then immunotherapy is the preferred partner. For those that CPS less than 5, then zolbetuximab is the preferred partner. But for those patients that between 5 and 9, then it is in a no man's land, a bit controversial, where some doctors may opt for immunotherapy if there's high disease burden, because in the study the response tends to be higher. But there are also other countries where immunotherapy is available in a later line setting, then it makes sense to expose patients to zolbetuximab. So your choice of systemic chemotherapy and zolbetuximab is perfectly reasonable.
Okay. So as usual, following 6 cycles, she had a neurotoxicity that pushed the medical oncologist to diminish and to stop the use of oxaliplatin. As you said, now the medical oncologist has many targeted therapy regarding the molecular biology, and this molecular biology is really important. This is a summary of the choice that we have now following for the treatment of metastatic gastric cancer. During many years, the systemic chemotherapy did not any progress, but now we really improve survival even for patients with peritoneal metastases. So this is a surgeon message that will be shared for everyone. I think that in this situation, the first treatment that should be delivered is probably systemic chemotherapy, and it should be the first line of treatment. Aditi, you want to comment?
I have a question. When the PCI is 17 on laparoscopy and clearly on the CT she has so much of disease, will you define the intent as palliative? And even if the patient has a very good response, will you ever consider this patient for surgery?
So this is the question to Wei Peng, because if it's the question is
or
for
to
me,
the surgeon, whoever.
Maybe we can ask to Clara Marie.
Definitely, I agree with Wei Peng and yourself in that systemic chemotherapy should be given. But I think in our side, perhaps we would do it a little bit differently. Because if we do see ascites and some suggestion of peritoneal disease on the presenting CT scan, we would actually counsel the patient for insertion of IP port during the diagnostic laparoscopy, because for us, if we find peritoneal disease at the outset, actually now our first line treatment would be to do bidirectional chemotherapy. So far in our center for the IP chemotherapy, we have been following the Phoenix regimen, so IP and IV paclitaxel. And then the systemic is quite dependent on the oncologist. Some would use S1 with the Phoenix trials. Some of them do use Zelox instead. But perhaps, so for us, I think, at a PCI of 17, I think it's still borderline. I think, we've seen, and I think Olivier will present later some results from the Phoenix and the Dragon trials. But I think at this point in time, we wouldn't write her off completely and say it's palliative. And we will be giving it in a neoadjuvant setting. But perhaps Wei Ping can also comment on if he would do anything differently.
Good point.
Wei Ping?
Yep. You hear me? So I agree with Karen that in centers where IP or NIPS is available, that's something can be considered based on the Dragon trial and also the Phoenix study. Then with regards to the question whether the treatment should be palliative or curative, I think this is controversial. In our center, if the patient, particularly young patient with good biology, and that it was converted after systemic treatment such that the cytology is negative, and the PCI score is low or even 0, then I think we would discuss the option of conversion, even though that it is still an area of controversy.
Okay.
I have a question.
Yeah, Beate, you want to?
Yeah. My question is also to the oncologist, I must say, to Wei Ping. We start with a young patient in a palliative situation, but why didn't we give him FLOT, which is at the moment the best treatment for responding to chemotherapy? Yes, it is not a curative intent, but if it responds, then we have a lot of alternatives to offer the patient, and perhaps at least we have 10% 5-year overall survival in some patients. So why not trying to start with a very aggressive chemotherapy? Just to answer, why do we give FOLFOX and not FLOT?
Okay, so perhaps here I would say that the main reason is because this patient is Claudin 18.2 positive and also PD-L1 CPS score positive. In such scenario, using 2 chemotherapy with reasonable toxicity and combination with either targeted therapy with zolbetuximab or immunotherapy would make sense. You're quite rightly said that about perhaps 10 to even 30% of the patient may subsequently be able to go for conversion. But we have to be mindful that large proportion, at least 70 to 90%, we don't want to expose them to unnecessary toxicity. So currently our strategy is that for patients that are HER2 negative, Claudin negative, and also PD-L1 CPS negative, these are the subgroup of patients. If we think that we want good response, we would use triple chemotherapy. But for majority of patients that have suitable for immunotherapy or targeted therapy, that tends to be our preference as a chemo backbone, with or without intraperitoneal targeted therapy like the IP chemo.
Okay.
Yeah, but on the other hand, if you give zolbetuximab, this is combined with a toxicity grade 3-4 in nearly 80%. So is this a real good drug for palliative treatment then, if you discuss this?
In fact, that there are studies that look at triplets versus doublets chemotherapy. The French did that study for stage 4 patients, and doublets is definitely more tolerable. So, and there's very little data to combine triplets chemotherapy with immunotherapy and targeted therapy. Hence, for patients for stage 4 disease, we tend to choose the regimen that are less toxic. And here we think that the doublet would make more sense than the triplets chemotherapy backbone.
Okay. Knowing that more and more the tolerance of zolbetuximab is now well managed, especially in France, with appropriate symptomatic treatment. So it was well tolerated, especially in this case. Signet, maybe you want to discuss this initial management. Would you perform bidirectional chemotherapy?
Yeah, so we have started. I mean, if this patient had, was not resource constrained, what would be good for us would be to start with single dose of PIPAC, because in our experience, the PIPAC, which we perform with our local device, gives very good control of ascites with just one single dose. We would also put an IP port at the same time and start with probably FLOT, because zolbetuximab is not easily available. And because it's a young patient, FLOT would be our drug of choice. I mean, the regimen of choice with or without nivolumab. So that's probably what we.
Okay, thank you, Signet. I propose to advance.
There is a question in the
yeah.
chat. We consider bidirectional PIPAC with nivolumab, considering the high PCI.
It could be effectively an option. I will discuss this use of PIPAC, and maybe Clarisse can make a comment. As you know, we did, and Clarisse directed one trial in gastric cancer, comparing chemotherapy to chemotherapy plus PIPAC for patients that were not resectable. And it was unfortunately stopped for during the COVID period for many reasons. And our feeling with Clarisse was that we did not select appropriately the patient into this study, and probably that starting with PIPAC without doing any systemic chemotherapy was not a good idea. This is what and how we are managing patient now. Do you want to comment this, Clarisse?
Yeah, so this is what you said in our French randomized study, PIPAC-STOC. We had a lot of patients with a very large tumor burden with a very high PCI. The mean PCI was more than 20, and half of the patients were treated in second and third line of treatment. So we did not get to have a difference in survival. Even if the PIPAC was well tolerated, we did not have a gain of survival between the two groups. But we can see that if we want to perform more than 3 PIPAC and to think about a new trial or how to treat patients with PIPAC, so we need to select patients with lower tumor burden and mostly with good performance status, and maybe in first line. This is what we can say, but it's only something to think about it. It's not proven in my randomized study. So it's just, we can just say that if patients are already in second and third line with large tumor burden, PIPAC will not help with survival, and they will not have the full treatment with PIPAC. So we are not ready in France to start PIPAC in first line, because there is a lot of combine chemotherapy and immunotherapy that it's efficient. So for now, I think we need to do it with some randomized study. In France, it's difficult to get BiPAC in first line, I think, Olivier. I don't know if it's the same for your center, but because of all the randomized study and because there is a lot of IV treatment that is very efficient, I think it's difficult in first line to defend the BiPAC, but in second line, yes, this is, I think, the place to put this treatment and in randomized study.
Yeah. So especially effectively in France, we are not still ready, but maybe it will come to begin a bidirectional chemotherapy, intraperitoneal and intravenous at the beginning in the first line. But we will see that we are maybe okay to start this bidirectional chemotherapy following the initial response. So because of the neurotoxicity, the medical oncologist in another center decided to continue 5-FU only with zolbetuximab until September. So for 3 more months. And because of the good performance status of the patients, because of the long-term control of the disease under this therapy, they decided to refer the patients to our center to discuss something else or something different. So when she arrived to our clinic, we were in front of a very young female of 22 years old with lanitis, with an advanced primary tumor. I remind you that she had a lot of probably lymph node disease around the primary tumor. We had the infiltration of the transverse colon. We had this infiltration of the first jejunal loop. But we had, at this point of time, 8 months of response to systemic chemotherapy with targeted therapy. We had a perfect general status. We had an acceptable tolerance of the systemic treatment, except the neurotoxicity. And we had, at this point of time, a morphologic evaluation that was decided to be performed by CT scan. So, of course, for this poorly differentiated tumor, this CT scan was not so bad because it did not show any hyperfixation, even in the primary tumor. So I would like to make a small comment on this PET CT, especially for this poorly differentiated tumor. Maybe you know this prospective Dutch trial that compared the impact of PET CT and laparoscopy for the staging of locally advanced cancer to remain to everybody that if the laparoscopy lead to 20% of treatment changes, the PET CT only in 3%. So I don't think that this kind of exam is appropriate to evaluate the extent of this disease. And the other thing is that even if we had on this PET CT an objective response of the primary tumor, we all know that sometimes we have a differential response for the peritoneal disease. So for us, it was absolutely mandatory to repeat the laparoscopy. One word maybe from country that have experience of FAPI-TEP in this particular disease. We have, I think, no experience in France, but maybe in Asia. Weipeng or Clara Mae, do you have experience of FAPI-TEP? Do you use it in this situation for the evaluation of patients? Or Signet Aditi, do you have some experience? Maybe we will start with Singapore.
Yes.
We will start with Signet, with India.
Yeah, so we in fact routinely use only FAPI-PET for all Signet ring cell tumors. Seems to be much more reliable because post chemotherapy, majority of the Signets on FDG PET do not show any activity. There is always a good response, whereas a FAPI-PET gives probably much more information, less than laparoscopy, but definitely better than FDG PET. So we would in fact not do a FDG PET, we would do a FAPI-PET.
Okay, and we have information. You are not afraid that we may have with FAPI-TEP some false positive? Have we got now strong data to support that all what we are seeing are disease and
so I agree. It is not a decision making. It's not the decision making investigation. It's one of the data points along with laparoscopy that helps us make the decision.
Okay. Clara Mae, do you have experience in Singapore with this exam?
Yes, actually now we are starting to use more of the FAPI-PET. I think when we first started, again, it wasn't the standard of care, and it's still not. And we were seeing some good results compared to the FDG PET. So not just in the Signet ring cells, but actually for a lot of our tumors, gastric and colorectal as well. In fact, it was picking up more than the FDG PET, especially with peritoneal and especially with the lymph nodes as well. I think like what Sanket said, there still is an issue of how accurate it is. And so we're trying to, see how it compares to, of course, our diagnostic laparoscopy, which we're doing right at the start. But I think our issue now is also how does it compare to the diagnostic laparoscopy after we've given either systemic chemotherapy or for those with bidirectional chemotherapy. I think we don't know if it lights up again after chemotherapy. Is it response or is it reactive? I think that one we are not sure at this point in time. So we've actually just started a trial in a small number of patients looking at using the FAPI-PET because we're doing our diagnostic laparoscopies after every 4 cycles of IP chemotherapy. So with those diagnostic laparoscopies, we're doing a normal scan as well as a FAPI scan. So anything that is lighting up on the FAPI scan, we will then go in during our diagnostic laparoscopy to biopsy to see whether it correlates. Yeah, so we're still in the midst of that trial.
So if I understand well, for those who would begin bidirectional chemotherapy, in this case, the evaluation by laparoscopy would be mandatory every 4 cycles.
Yes.
Okay.
And then we're doing the FAPI at diagnosis and every 4 cycles with the diagnostic laparoscopy. Yeah. Okay,
perfect. Of course, we have several possibility to do this bidirectional chemotherapy and to do this intraperitoneal chemotherapy in addition to systemic chemotherapy to better follow the peritoneal disease and perhaps to better treat. We have different strategies that were developed all over the world. I think that the laparoscopic IPEC, that was the method of choice for Brian Badgewell in USA, is still not using in his center. I think that now he's doing regular intraperitoneal chemotherapy. Maybe Yukata Yonemura is still using it in Japan, but in Asia, the most common bidirectional chemotherapy is given by IP-POR, and you know also that the third method that could be used is PPAC, that was perhaps a little more developed in Europe. We all know that intraperitoneal chemotherapy for peritoneal disease appears for in many studies and in this meta-analysis to give what we will call encouraging tumor response with a good safety profile and a conversion rate of approximately 16%. This is the results of Brian Badgewell in USA. So as you can see, he used laparoscopic IPEC to better select the patients that could be amenable to resection, and his results are better, of course, when the patient is responding and when the patient gets the resection. You all know this international data that was presented by Mohammad Ali Ami in the ASCO GI 3 years ago now, and which is still not published, but with the use of PPAC, especially when you can continue, as Clarisse said, the PPAC for at least 3 cycles, we can get overall survival that are really interesting at 20 months. Unfortunately, we were not able to demonstrate this into our phase 2 randomized trials that was stopped, but the safety profile was adequate, and adding PPAC did not decrease the overall survival. You all know, of course, that the better results were obtained with the use of regular intraperitoneal paclitaxel. The first experience was reported by Ishigami into the Phoenix trial. This study was negative on his primary endpoint, but after 1 more year of follow-up, it became positive. And more recently, as you mentioned, everyone, we had the Dragon 1 study that was positive, and that compared intravenous chemotherapy alone versus intravenous chemotherapy plus intraperitoneal paclitaxel, and the difference in terms of overall survival was really significant with a high hazard ratio. So in France, we decided to introduce PPAC, and we are using since 2 years now the PPAC with the use of nab-paclitaxel following the publication of phase 1 study. We found a PCI that appears to be decreased at 15. The cytology was negative, and we did some peritoneal biopsy, but only on the parietal peritoneum, and this biopsy was negative. I remember you that we have now some phase 1 and more recently a phase 2 trial that was reported by the Wim Selen team at 140 milligram per meter square with a good tolerance profile that allow us to use the nab-paclitaxel intraperitoneally during PPAC. So this is what we used for this young woman. And every 2 cycles of systemic chemotherapy, we did a laparoscopy with the PPAC of nab-paclitaxel. For the second, usually we are not performing peritoneal biopsy. That may cause sometimes some problem, and we redo peritoneal biopsy at the 3rd PPAC. As you see, the PCI was decreasing. I think that the evaluation was different because it was different operators, and there is a big heterogeneity in the evaluation of peritoneal disease during this laparoscopic evaluation. Following the 3rd PPAC, we begin to think about a more ambitious treatment. So we decided before the 4th laparoscopy and the 4th PPAC to perform a CT scan and to look at the pathologic results that we get from the previous laparoscopic evaluation. So it was 3 months after. And as you saw during the laparoscopy,
Am I knocked out or is it?
I'm out also, Aditi.
Yeah. I think it's Olivier who's locked out. Yeah. Dr. Sugarbaker, you haven't said anything yet, so do you
Well,
want?
I'm just listening. It's an excellent presentation, Aditi. And I tell you the truth, that the storyline that Olivier is developing, I think, is really very nice. But I'm not getting anything except from you right now.
Nobody else is speaking. So I had one question for Wee Peng. As a medical oncologist, which patients, if the facilities and expertise is available, what would be your indications for IP chemo in first line?
My personal bias, of course, would be with NIPS, which is the IP chemo following the Dragons and the Phoenix trial. Reason because it's the strongest data in terms of the level of evidence for now. And there's also good rationale, mainly because by giving IP chemo, we can maintain the dose intensity and the frequency that we think that is important to exert an effect in the peritoneal disease. So where the challenges with single doses of high-pack or single doses of high-pack may not be able to deliver the intensity and the frequency compared to the IP chemo. But that said, their strategy, for example, Olivia has mentioned that in MD Anderson, they start doing laparoscopic high-pack, and that definitely would increase the frequency and intensity. So similarly, high-pack may be, but in terms of level of evidence, my bias is still with IP paclitaxel.
Okay.
I'm sorry, I don't know exactly when you lost me, and I'm really sorry. This is my internet connection. So to summarize, she had 4 PPAC, and in January of this year, we were in this situation, PCI of 9, morphologic evaluation with negative cytology. All the biopsy that were performed during PPAC were always negative, but were only done into the parietal wall. And we had one problem because of the peritoneal hemorrhage that she did at the beginning of his evaluation. We had no pelvis access. So this treatment was very well tolerated with absolutely no adverse effect. This is the CT scan before the PPAC 4, so no disease extraperitoneally. Very good response on the primary tumor, and this primary tumor was apparently potentially removal from the head of the pancreas. We still have some infiltration in the mesentery, in the left part of the superior mesenteric artery, with still infiltration in the first jejunal loop, but no ascites, no more disease elsewhere. So the confirmation of what we are seeing in laparoscopy, very good response. I put also all the photo that we took during this fourth PPAC. As you can see, we had some adhesion around the liver. We have this area in which we have some scar where the biopsy were performed.
Cannot see. We cannot see.
You cannot see what?
The video.
My screen?
Yeah.
This is not a video. This is photo.
Okay, no, even we see you, but not the photo.
You are not looking.
I see the photo.
I can
okay,
I can see it. Yeah.
Okay.
Yeah.
Yeah.
Okay. So we have some scar also on the right column. You can see in the lower part, and the diaphragmatic cupula on the left side was free of disease. So in this evaluation, especially when we want to discuss resectability, I think that especially in this pathology, is absolutely mandatory to improve our evaluation by doing this small laparotomy to combine the visualization and the palpation. Because you may have, it was not a photo from these patients, but that illustrate what we can have in this pathology, the infiltration of this mesenteric part of the small bowel that will lead to a non-resectable case. And for every patient for who we will discuss the cytoreductive surgery, we are performing at a point of time this evaluation to be sure that we will not miss any disease. So following this PPAC4, we have a great and extensive discussion, not only in the multidisciplinary meeting, but also with the patient and her family to try to find the good decision between procedures with curative intent or aggressive procedures to remove the disease and the continuation of the palliative management. Of course, you have in this case, especially in a young woman, a very difficult choice to make. You all know this very important part of the selection process for curative procedures that should imply not only the patient condition, but also the center, and especially for gastric and gastric cancer, the center where the patient will be treated, the extent of peritoneal disease, the control of the tumor, the molecular factors, and the major prognostic factor, the resectability of peritoneal surface malignancy. So at this point of time, I would perhaps give the talk to Paul. Paul, what would you decide for this young woman?
Well, that's a difficult question, Olivier. You'd have to look this family and this young girl right in the eye and say, listen, we have a treatment to offer you, a surgical treatment, but its likelihood of helping you is less than 20%. And you seem to be doing extremely well at this point in time. It's really a difficult decision. I would encourage her to go ahead with a surgical procedure. It seems as though she has a control of the disease. I think that this is a window of opportunity to render some therapy that will render her a longer life, perhaps not a cure. In my experience, when you wait too long, the gastric cancer, the primary gastric cancer, begins to give a lot of trouble. And so getting rid of the primary cancer, getting rid of gross disease, and then trying to get her back onto her combined local, regional, and systemic treatment. So the goals for us would be, yes, to resect, but then to get her back on a NIPS type of treatment or PPAC plus systemic chemo type of treatment. I think one of the things we've learned from Dr. Ishigami is that you can't stop. You have to keep moving along with the bidirectional treatments.
Okay, Beate, would you propose surgery to this patient? Would you have proposed this surgery perhaps earlier in the course of the disease, or do you think this is the right time to propose it?
So how long is now the journey of the patient?
1 year.
1 year.
Yeah.
And stable.
And response at the beginning,
Yeah.
response intraperitoneally following 4 PPACs, because when you compare the first exploration that we did in our expert centers and the fourth exploration that we did at the PPAC 4, we certainly have a peritoneal response in not only in the pathology, but also in the evaluation of the peritoneal disease.
And the patient has any symptoms?
No, but as you imagine, following several cycles of systemic chemotherapy, PPAC, for a young woman of 22 years old, it begins to be psychologically a little difficult. I noticed that it was well tolerated, but following the systemic chemotherapy and even following the PPAC, she needs some days to recover. So it begins to be a little difficult. Not impossible, but a little difficult.
It is, as Paul said, it is a very difficult decision to go. I think we are always able to do something resectable and so on. So this is not that difficult. But the difficult is what I have to realize sometimes, that if I then decide to perform the gastrectomy, then half a year later they recur. And then you have only small bowel, and it's difficult for them. But yes, if it is possible, I think I would go for surgery.
Okay. Wei Peng, if you had these patients in your clinics without any surgeon around you, would you keep her for you, or would you propose to Clara Mae to evaluate her for surgery?
I think the figure you show there is fantastic. I'll just going to go through my mind. For patient's condition, I think this is a young patient, fairly good performance status, so that's a plus point. From the tumor biology, patient have good disease control for 1 year, and the great thing is that cyto is negative. So in my center, the cyto have to be negative before we go in. Now, with regards to my center, because we tend to be a little bit more conservative, we tend to go in when we absolutely did not see any positive biopsy. So in your case, while your PCI score is 9, it is still higher than the cutoff of 7, but all the random biopsy are negative. So that again is a positive thing. So I think the bottom line, then I will ask my surgeon, is that are you able to get the R0 resection? So we do know that for the 2 phase 3 trial in the Dragon 1 and for the Phoenix, the subset of patients that do fantastically well with the median survival about 40 months are those patients that have R0 resection. So if let's say my surgeon tell me that, hey, biopsy are negative, cyto is negative, I can get an R0 resection, then I'll give them the blessing.
Okay. Clarisse, in Lille, do you think that this patient will be operated or not?
For me, what you said and what we learned from gastric pec, I think from Beate, it's that we need to give some time for the selection, because a lot of patients, maybe majority of them, will just draw up of the curative treatment. So if you have 1 year of good response and stabilization of the disease, and your cytology is negative and everything is very stable, she's young, I think for me it's a good candidate. The problem is the extension of the disease, and in France we remove all the primary tumor, but also the peritoneum that we think is healed.
Involved.
Yeah, so you will do a very extensive surgery. So yes, we have to discuss about that, because but yes, I think the good criteria for this patient is that it's 1 year of stabilization and good response with cytology negative, and also you have some biopsies that are in very good response, right? So
Yeah, okay.
it's
Okay,
it's
so
now or never.
yeah. So as you said, CRS and IPEC is today the only treatment that can achieve cure. Long-term survival, maybe I will have to change, because sometimes with this bidirectional chemotherapy, we may obtain some long-term survival. But what is long-term survival for a patient of 22 years old? Of course, patient selection and personalized selection is the key. But this is the same thing for targeted therapy and immunotherapy. And the completeness of cytoreductive surgery should be CC0. And in this old data, because when we get this data, we did not have this this better perioperative management. This new targeted therapies, this better response is perhaps something that may that allow us to get better results also with surgery. So we know that we can cure, and Clara Mahé showed this in our experience in France, in the patient that we selected for peritoneal metastasis from gastric cancer. You can be cured, but only if you have synchronous disease. As you saw, the PCI, the median PCI at the point of the resection should be very low. We are, for this patient, a little higher. CC0 resection, of course, but we had, as you can see, some patient in this experience that had the poorly differentiated tumor. We know also from the Beate Rao trial, the gastric trial, even if it was not totally conclude, that in the subgroup of patients that were able to be treated by a CC0 resection, the use of IPEC improve the survival, and we get some long-term survival. So once more, CC0 and IPEC may lead to better results. We know also, especially in our experience in Lyon Sud, that by starting PPAC for patients with the palliative intent, and it was exactly this case in these patients, we may obtain patients that could be converted to curative procedures. In our experience, approximately 15% in gastric cancer. And we know that for patients that had this bidirectional chemotherapy, that when they get surgery in the Ishigami experience, we reach median survival that are over 30 months. And it was exactly the same results in the more recent Dragon 1 trial, even if in this case, most of the patients have only gastrectomy and not peritonectomy procedures. So after extensive and long discussion with the patient and the family, trying to moderate, of course, the enthusiasm that it's normal to get from a young woman to who you are telling her that you may be able to do surgery. So reminding her and to the family that even if we are doing this kind of procedures, the chance of long-term survival are not so high, the imaging. We decided to do a prehabilitation and to perform in February cytoreductive surgery and an IPEC. So we did first, of course, as always, the surgical exploration, and one of the important messages is not to go ahead before knowing exactly what you have, exactly what you should do for a complete cytoreductive surgery. And sometimes, especially for gastric cancer, especially following an extensive preoperative morphologic workup, you have some difficulties. And the first difficulty was to appreciate the resection of the primary tumor because we still have an involvement of the first duodenum after the pillar, but that could be dissected from the head of the pancreas. And we have also an involvement of day 3 following the insertion of the biliary duct. So my first question was, should I perform for the primary resection a duodenopancreatectomy resection? Can I conserve the D2, or should we decide to open and close because of this massive involvement? It was the first question that I had. The second question was, what about the preservation of the fertility? Because I had some scars on the pelvis and on the ovaries, but not knowing if these scars were involved or not. And my third question was regarding the scars on parietal peritoneum, because she had, at the beginning and during our evaluation, some disease or some macroscopic disease, but with negative biopsy on this parietal peritoneum. So should we perform parietal peritonectomies? So for this 3 question, maybe I will ask to Signet what would be his strategy at this point of time.
Sir, I would probably close this patient. And since you have not used IP port, I would probably put in an IP port and consider the Phoenix GC type of treatment. She's also not exposed to S1. So S1 with IP port directive would be my choice. I don't think fertility preservation is an important question, especially considering the limited lifespan that we are expecting for this patient. And neither, if you're not resecting the primary, then peritonectomy is obviously out of question.
Okay. Paul, what would you do in this situation?
Yes, sad news that indeed the pancreas will need to be resected. We've done on some recurrent cases this jejunal advancement procedure, but I've never done it with a gastric cancer. I think she needs a diversion. She needs something, a gastrojejunostomy, I think would be indicated, because the primary tumor is going to view trouble in the near future. My problem with peritoneectomy after response in gastric cancer is that it seems to be very messy. It's not like doing a peritoneectomy with a mesothelioma or a colon cancer, or certainly not with a pseudomyxoma. And I would only, the only really peritoneectomy that I try and do in these gastric cancer patients is the greater omentectomy, lesser omentectomy, and a clean out around the stomach. I don't have any luck with the extensive peritoneectomies from underneath the hemidiaphragms. So I would just do a diversion procedure and remove extensive disease that's easy to remove. Of course, you'd like to leave the ovaries behind if you can. If not, of course, her fertility is not the issue. It's her ovarian function that's the issue. But it's too bad that she had this deep invasion. And for me, pancreatectomy with a gastrectomy is not a procedure that's been successful for me.
Okay. Clara Mae?
All three questions into consideration together. I think with the difficulty with resection of the primary tumor, I think adding on a pancreatical duodenectomy would be too big for a gastric cancer. And I don't think we will go ahead at this point. And I agree with Paul that she probably needs some sort of bypass procedure, because that's probably going to cause some problem at that point in time. So if you see number one, I guess 2 and 3 are kind of, you wouldn't go ahead with that anyway. I think the problem, as Paul pointed out, I think with the question number 3, if let's say you could resect the primary tumor, I think fertility is, not an issue here. We would probably have referred her to our gynae colleagues, and, the ovarian function can be dealt with medication-wise. I think the problem for us is always the parietal peritonectomy. And that would be a consideration right at the start, because even if your cytology is negative and your biopsies are negative, how do you know it's really negative if you're still seeing scars there? And for us, a lot of the times, because we're using bidirectional IP chemotherapy, you do see a lot of scarring from that. So my considerations right at the start would be that PCI of 9. Where is that PCI scoring? Because we know 9 can mean a lot of things depending on where that peritoneal disease is. And if that 9 is somewhere on the parietal peritoneum and it's easy to resect, and we're going for a full reductive surgery and IPAC, then I would probably try and strip all the parietal peritoneum that is visibly still scarring.
Mm-hmm. Yeah, but regarding the bypass procedures, I remember you that the patient was totally asymptomatic. She has lanitis. So are you still recommending bypass procedures for an asymptomatic patient that is controlled under systemic chemotherapy?
I think if she's completely asymptomatic, then it would depend on whether perhaps on table, if we put a gastroscope through, would it be easy to get through, or do we think that, how tight is it, and how soon is it going to cause problems? Because at some point in time, we are going to lose control. The whatever treatment that we're going to give her may stop working, and so a bypass procedure wouldn't hurt if she does miraculously respond further down the road. We have done some cases in which we've gone back in after a bypass procedure to do a complete cytoreductive surgery and HIPAC.
Mm-hmm. The problem with by doing in general parietal peritonectomy for gastric cancer is that if you want to continue following this kind of procedures, intraperitoneal chemotherapy, you jeopardize the chance to continue this intraperitoneal chemotherapy. This is one of the issue, and one thing that opposite the Asian guy and the European guy, some of the European guy.
Yes, I think
Okay.
the Japanese criteria to do the conversion gastrectomy or conversion surgery is really very strict. They have to see complete resolution of the disease, and that's probably why their results are so good. For us, we don't continue the bidirectional after the CRS and HIPEC. We would do the CRS and HIPEC, and then if they've completed all their systemic and bidirectional, we may stop the bidirectional. And if they haven't completed their systemic, we will give some more cycles of that. We do leave the port in just in case we ever need it again, and we haven't had issues with that. But yes, we don't continue our IP.
Okay. Berthe, you would also do an open and close procedure?
Yes, I think, because you have to wait between complications and treatment of systemic chemotherapy, immunotherapy, whatever, which is important for the patient. So I think I would not go for a Whipple procedure. And if there is any, if the ovary looks very okay, I wouldn't do anything. But if I have the insight that one of the ovaries is extending, looks like ovarian metastasis, I would remove this selectively. But when I will remove one, I would remove two. And I think this will be good for the patient. What I would not do, I would not give her a diversion ileostomy or something like this. I don't know if this was discussed, but I think this is not good for type output, and I think it will not help really the patient. And if you say that it's a linitis plastica, patients to have a bypass procedure is also difficult in anastomotic healing in this situation. So then I would just let close again. Yeah.
Okay. So finally,
could I ask Olivier?
Yeah,
Could I ask?
yeah.
Is there anybody who would like to go ahead? Anybody on the call that would go ahead with the combined gastrectomy and Whipple procedure? And if they have experience with that?
The only surgeon that I did not ask is Clarisse. Clarisse, you want to?
Yeah, so I will not go with a Whipple procedure. I will start with what is easy and what is not easy to do, and the problem during this kind of surgery, because she has some polycohesive cells. It's very difficult to have a pathological exam during the surgery that can be that we can trust, because during the surgery, if it's not positive, that with a definitive report will say that it's positive sometimes, like in half of the time. So for me, the resection of the peritoneum on the abdominal wall and everything is not a big problem. The preservation of the fertility, it's difficult, but I think if we do the surgery, we will remove the ovary, I think. The question I was asking in my head is, what is difficult is that we need to be R0, have a R0 resection on our gastric cancer. So if you remove the tumor, if you feel that you can have a R0 resection, I think you can do what you just did with this surgery. But if you have some positive section during the surgery, I will stop and not do the Whipple after after the section of the stomach. So I will probably do the gastric surgery, and if it's positive, I will not go further with all the stuff that you did, because you also will have a lot of anastomosis that will be a risk for the morbidity. So yeah, if you can be a 0, do everything, but if no.
I understand all your comments. So the majority and the totality probably of surgeons will not go ahead. It was possible to remove the disease because without removing the head of the pancreas, because we had a plan, and it was possible to dissect the first duodenum from the head of the pancreas and to cut in normal tissue. Of course, we all know that especially in this pathology, you can cut into normal tissue and get some microscopic involvement, but it was possible. And I removed the gallbladder and I put a drain, a transfixic drain to repair the arrival of the biliary duct into day 2. And it was also possible to dissect the left part of the mesenteric artery. I had no big lymph node around this region, just an infiltration. So I decided before cutting and before going to resection to be sure that it was possible. So because it was possible to keep the day 2 and remove disease apparently in normal tissue, and because I have no other big disease into the abdomen, because my PCI was limited around 7 to 8, I decided to go ahead and to remove the transverse colon and to remove the ovaries. So to play the game, to try to give her a chance of eradication, even if, as you all said, very low and perhaps null. So the pathologic report was a little disappointed on the primary tumor, but not disappointed on the evaluation of the other specimen, because we only have 2 lymph nodes on the 24 lymph node that was evaluated, but with an evaluation of no response on the primary tumor and a better response on the peritoneal disease in the transverse colon on day 1, day 2, and day 3. We had no other lymph node, no other peritoneal involvement on all the peritonectomy that I did. The only problem was the involvement of the superior part of the D2 resection. So in this area, where I cut apparently in a normal tissue, I did at the beginning of my experience a lot of intraoperative evaluation, but unfortunately I had several evaluations that were negative operatively, and that was finally positive in the post-operative evaluation. So today I decided not to continue to do it. So the post-operative course, she did, of course, pancreatitis with some intraperitoneal collection that were drained, but she recovered well. She is eating with fraction. We still have a parenteral support, but usually I'm using a parenteral support for every gastrectomy for at least 1 month following the procedures. And we discuss the case in the MDT to discuss the adjuvant treatment. We all said that it will be great for her to get additional cycles of 5FU. The question is regarding the targeted therapy. Some of us would like, but it's not validated by trials. Wei Peng, what would you do in this young woman that received it preoperatively, that's responded for a long time? What would you do in the postoperative period?
Okay, very tough question because there's no clinical trial to guide what to do. My thoughts are that if it's truly non-R0 resection, then I would offer to continue systemic treatment with 5U and ROBI, let's say the regulatory body in your country allowed that. Just because I do think that if there's disease left behind after she have gone through so much, I would still like to continue the systemic treatment.
Without stopping at any time?
Probably not, unless toxicity is an issue. Otherwise, typically we continue to give until disease progression. But that said, I'm also aware that one of the reasons for her opting for surgery is so that she can stop systemic treatment. So in the end, I think it's a discussion that there's no right or wrong, but I'm just a little bit concerned that it's not R0. So I'll err towards continuing, but I can accept it if she choose not to.
Okay. Beate, in Germany, would you discuss on R1 positivity, the radiotherapy, on anastomosis, on suture, in addition, or not? Your microphone, Beate.
The problem here is that it is now an anastomosis in the small bowel area, which is difficult because you only are allowed to give 25 gray, which is perhaps not enough to treat the R1 situation. I did this once in a patient where I had an R1 resection in the esophageal situation, and everything was nearly complete, and also for pathology. And I had to go back into this patient's half a year later or something long. I have to look it up, but it was a long time later. And what I had to realize is that the area where the radiation treatment has been done, so around the upper part, down, there was nothing. But just outside the radiation field, there was peritoneal metastasis recurrence. So this was funny, but anyhow, it was the only patient I had this experience. To radiate in the area of the duodenum in the anastomotic field, I think it might be difficult. Whereas you said this is the only area for something. So if the radiologists or the radiotherapists will say, okay, I think I would also recommend. But I'm not quite sure whether a radiotherapist will indicate for radiotherapy in the patient. I'm not quite sure. It's a difficult indication.
Okay.
Yeah, and chemotherapy, well, patient first has to recover, so I think it needs to be a long time, and then you have to discuss whether this is worth or not. Well, if there's no complication and patient goes home and he can start with the chemotherapy in between 3 weeks, then it's fine. But if not, difficult.
Yeah. Sanket, you want to comment on this adjuvant treatment, even if you would not operate, you will close this patient?
Mm. Yeah, I think S1 might be an option, is what I would think my medical oncologist would consider. And there is still immunotherapy that has not been used, so I think that would be a good option. Very well tolerated combination, so perhaps that would be the right thing. And IP paclitaxel, we would continue with that.
Okay. Okay. Clara Mae, when you are performing such curative procedures, did you already try to restart this IP chemo? Did you have the experience on it, and is it possible?
Immediately after the surgery or on?
Yeah, IP chemo after this kind of surgery, because apparently you are using it preoperatively.
Yes, but we don't, if we're doing the CRS and we give the HIPEC, then we don't give the IP chemotherapy after we stop.
Okay. Okay. And finally, Clarisse, what would you do in Lille when you have? I imagine that despite you are a great surgeon, that sometimes it happens to get some R1 resection. Are you using additional radiotherapy or not?
No, we are not. No.
Yeah.
There's,
Okay.
Are you? Because I don't think there is any proof that it's very interesting for this kind of problem.
Yeah, usually following the, we are using normally 4 additional cycles of systemic chemotherapy. And when we
Systemic,
had,
yes.
but when we had a big lymph node involvement in the regional area, and sometimes R1 involvement, we are pushing our radiotherapists. If the evaluation on CT scan show apparently control of the disease, to do this additional radiotherapy to try to improve the local regional control. But it's not so easy to convince them, of course, of the potential benefit, and I have no data to demonstrate that we should do like this.
We discuss this sometimes with my my colleague, Professor Piesen, who is a gastric oncologist, surgeon. So, and we don't do it. But you think it's to treat the bowel that you left, the duodenum that you left, or the lymph node involvement that you resected? What do you think? Because if it's only to treat the R1 resection, it's I don't know.
This is the reason why I push my radiotherapist, and I will push them to do it if things are going well, because this is not an anastomosis. This is the section of the duodenum at the end of the pancreas. The anastomosis is lower. So with radiotherapy and stereotaxic radiotherapy, it could be efficient. So, but we will do it, of course, step by step. Unfortunately, I have not the end of the story. Following this discussion with all these prestigious experts in the world, I'm not sure that I did the right choice, because you probably all would do differently. So we will see. I think that this kind of surgery should be evaluated in the future. The indication, and we know that we have this very interesting international trial that will try to demonstrate the benefit of not of this conversion surgery for patients that are not amenable to curative procedures at the beginning, if they would be, and that become resectable. Should we operate them, or should we continue the palliative chemotherapy? We will start in France. It started in Singapore. I'm convinced that it is a major trial and a very important trial to try to get some answer that we still do not have. And as you see, a lot of collaborators are participating. Selection is the key. As you saw, I did my selection preoperatively, selection intraoperatively. We would not do exactly the same, and I think that the discussion was really interesting. I don't know if one of you wants to give a final comment, perhaps Paul?
Well, the thing that's most striking here for me is a surgical issue. Olivier, congratulations on this. I usually call this the jejunal advancement procedure, but I always use a roux loop rather than this attachment to attachment to the jejunum as you have done it. This is a very good operation for recurrence of a right colon cancer that involves the head of the pancreas. I've not used it in gastric cancer. I'll be very interested in the follow-up on this patient. I guess right now we really can't say whether this was surgical momentum that brought you to finish this case, or whether we're going to get some mileage in terms of another year of good survival, or maybe even another 2 years of good survival in this patient. So I would say congratulations on a very technically demanding surgical intervention that hopefully will bring this patient some good time, some good high quality time.
I hope we will see, and I will inform all of you. So we do not have to continue too much, because Aditi told us that following 90 minutes, the YouTube will not be seen by many.
In that case, can I ask one very candid question?
Yeah, of course, Duncan.
Can have closing remarks.
Yeah, so before the closing remarks, I want to ask, given this same situation again, would you still conduct the same surgery? That's one question. And second is, how do you manage the nutrition after this surgery? Do you use a nasojejunal tube? Do you do a feeding jejunostomy? Do you continue IV nutrition? And if so, how long?
I will continue the IV nutrition in complementation to oral nutrition with oral complements that she's taken now until the post-operative clinics that will be scheduled in 1 month. I hope that she will be able to restart the systemic chemotherapy at 2 months, 2 months and a half. This is what we schedule, and I think that regarding our general status today, it will be possible. And we will do both oral nutrition, but without nasogastric tube, a nasojejunal tube, and parenteral nutrition with fraction alimentation. Other closing remark? No? Aditi, do you want to do some closing remark and introduce the next case of the month?
So I think when we were going to have this case, the question was for me, after Periscope and after Renaissance, are we going to still recommend surgery? I think from the whole panel, including the medical oncologist, it is a whopping yes. So the surgery, yes, but here we've just pushed all the limits, and it would be really interesting to see how this patient does uh, in this year itself. And one more thing I want to say is, it's what is a survival that the patient values, a DFS that the patient thinks is worthwhile. In our country, if they don't get 1 or 2 years of disease-free survival, then they are not happy with the surgery. So I think into the discussion, apart from the morbidity, it would be the recurrence and when it occurs. Yeah, so that's my perspective, and I think it was a really interesting case, and the diagram was really beautiful, and we had a great discussion. So thanks to you for presenting this wonderful case, and thanks to all the panelists, especially Clara May and I think it's past midnight. It is already the 21st. And we'll close the session. There are no questions or comments in the chat. Do you want to say anything? Or anybody else?
No. Okay, so once more, many thanks to all the panels. The discussion was rich, very interesting. Many thanks for your honesty, and I hope that I will see most of you in the SO meeting next week. I will present another case like this, but with a long follow-up, you will see.
Okay.
So for those who are there, our next discussion is on the 17th of April at the same time, and it's on locally advanced colorectal cancer. And the discussion is there on YouTube, and it's there if you want to watch it again or come back to it. So thanks to all those who attended the discussion, and
Good night, good evening to everyone, and good
Thank
morning
you all.
for the other.
Great
Bye.
presentation. Bye-bye.
Bye.
Thank you, Aditi. Thank you.
Okay.